Yes, all right. Okay, so we're going to get started. I want to take this time to introduce our dear sister, Jessica Dawson, who will be speaking to, again, some of the medical mistruths regarding gender dysphoria and transgenderism. She's got a long list. Where's my planner here? She's got a long list of qualifications, which I'm sure she'll share. But I pray that you all just be ready, take some notes, because her last message was jam-packed with lots of important tidbits that I believe will be handy as you minister to a completely different sector of the LGBTQ community. And I say this because their struggle is just so much different than that of somebody who's just same-sex attracted. So without further ado, I want to bring up Jessica Dawson. Thank you.
Thank you, Gabe. Aloha. Mwah. Okay, yeah. All right, I'm happy to be here. I think the audio is okay. All right. A little bit of an intro or bio. Jessica Dawson. I am a certified sex therapist, licensed mental health counselor, and nationally certified counselor working in the space of sexual health. Two of my specialties are sexual health and eating disorders, which are interestingly the topic I'm talking about today, gender dysphoria and transgenderism. There's a lot of interesting overlap with eating disorders, so I do kind of weave that in. Okay, so my message today is on just unpacking some of these medical terms. It's a little bit clinical. I guess that's the way my mind works, and that's my experience. So I'm going to try to break down some terms and terminology and put some just information into what this means in today's culture and today's mental health field. So understanding gender dysphoria. We'll go to the next slide. The clinical definition of that is a marked incongruence between one's experienced gender and assigned sex, lasting at least 6 months and causing clinically significant distress or impairment. This is taken from the Diagnostic Statistical Manual of Mental Disorders. That's not my definition. I would change the word assigned because it was our birth sex. But this is taken from a medical manual, essentially. This is a diagnosable mental health condition that is given if someone is struggling with this kind of incongruence or distress for 6 months or longer. The distress is usually centered on body incongruence, social rejection, or an internal conflict. It's also important to know that typically people who present with this symptom, they are also suffering from other mental health disorders. So there's a large amount of comorbidity in this particular presentation. Often depression, anxiety, trauma history, and other developmental or neurodivergence. So I like to say, neural diversity. There's a lot of brains, and our world needs them all. They all operate a little bit differently. But there's a lot of, sometimes if people don't feel like they fit in or fit the mold of a typical analytical, studious student, they fall outside the realm of that box that we put people in, and then they tend to feel a little bit more of this. So the prevalence, and the reason that this is an important thing to know about and be talking openly about in our church and in our culture and in our mental health world is the fact that the prevalence rate has increased significantly, shockingly. It's very concerning. Currently, the number of youth in the United States that identify as transgender is about 3.3% of the population of teenagers between 13 and 17. So that's shocking because that's about 1 in 30, just to give a little bit of numbers to it. This is new. Roughly about the last decade has this spike of prevalence happened. Previously and historically, gender dysphoria has only been seen in 0.01% of the population. So it's super rare. You'd be a therapist and never see this in your entire lifespan of mental health work. And in fact, prior to 2012, there were 0 documented cases of young girls, females, having gender dysphoria. It was historically male presentation only, and there was no scientific literature suggesting this was even happening to girls. So we have to ask ourselves, why? What's going on? And this is not unique to the US. Other Western countries are reporting similar prevalence spikes. I do mention, so there is some authors, and there are some researchers, and there are some professionals who are describing this as a social contagion, and I think that's worth mentioning. Suicide has long been known to be a social contagion. It's an ideation. It's an idea of a solution. And that idea is something that, once it is identified as a possible solution, not a good solution, it is adopted by people and often duplicated by others. So we do know that some mental health conditions, multiple personality disorder is one that had a social contagion presentation, and anorexia, eating disorders also do. I bring that up because anorexia and gender dysphoria are typically, they happen to individuals when they're transitioning from childhood to adolescence or adolescence to adulthood. So there's a natural biological transition happening where there's a lot of confusion and a lot of challenges that they might be facing, and trying to understand that. Both of these mental health diagnoses they happen when an individual fails to maintain a sense of coherence between the body and the self. So they're essentially psychological conflicts played out on the body. The body is the war zone. Oftentimes, this is because there's some sort of underlying suffering. There's some sort of conflict happening within that individual's mind that creates a solution. The solution is often through one of these means of self-starvation. They're both what I would describe as body shaming. I think they're both presentations of body shaming, where someone with an eating disorder doesn't feel good about themselves, and their way to control how they feel about themselves comes through self-starvation, binging, purging, excessive dieting, excessive exercise, things like that to try to control how they feel. Similar with gender dysphoria, someone doesn't feel good about fitting in, like Pastor Gabe said, fitting in, or doesn't feel good about something that they feel powerless over. And gender dysphoria is a coping mechanism that takes them from a place of feeling paralyzing powerlessness into feeling a sense of power. It comes with a plan and a script. So with anorexia, society is on board with this particular mental illness, where with anorexia, there's a pretty prescribed treatment protocol. They're put on a meal plan, and when their brains are nourished properly, they typically loosen the rigidity of thought that creates that kind of all or none thinking about their body, and they start to feel better. And it's really very obvious to the rest of the world that people who are emaciated are not fat. So it's strange to understand that they can have this extreme distortion about how they see themselves compared to how the world sees them. So with eating disorders, they need to be taught coping mechanisms to alter the distorted thoughts. This isn't happening with gender dysphoria. Instead, with gender dysphoria, the world is encouraging it. The world is telling them that their thoughts and affirming them. So that's just worth knowing. Some in the professional realm are calling gender dysphoria anorexia 2.0. We'll go to the next slide. So there's different types of gender dysphoria. Child onset. This is historically when you would have, that 0.01% of the population, that was typically how this presented, was early in life, early childhood, historically the most common. So 70 to 90% of the cases documented were of this presentation. Late onset gender dysphoria is usually happening around puberty or post-puberty, where there's some sort of sexuality component to it. It can often, and it's a bit controversial even in the field of sex therapists, but this concept of autogynephilia, where there's a sexual attraction to self as an opposite gender, expressed gender. And then there's gender dysphoria associated with disorders of sexual development. Sometimes you hear people discuss that, it's not their fault, they were born that way. So this is what they mean by, this is that category of individuals, and it is a true medical complication where someone who is, the term is intersex. There's about 40 different conditions that can happen during the conception process and the process of a developing embryo, where there can be disorders and dysfunction of the sexual development. So some examples. These are people who, like Pastor Gable talked about briefly, these are people who are born with sometimes both male and female genitalia. And there are some different syndromes. One is Klinefelter syndrome. This is a genetic male who is born with an extra X chromosome. So they actually have XXY. And they're therefore going to develop more feminine characteristics, sexual body parts and characteristics. Another one is androgen insensitivity syndrome, just to give you a couple ideas of how this, when people talk about this isn't their fault, what some of those presentations are. This is another genetic disorder with a genetic male whose body can't respond to testosterone. So they're going to develop and be more feminine in appearance and more androgynous characteristics. And then we have rapid onset gender dysphoria. And this is, the acronym is ROGD. This is a recent phenomenon. This is not a clinical diagnosis. It's not scientifically been studied because it's new. This is what we attribute this spike of the last 10 years. A lot of these cases fall under this particular category, rapid onset. Rapid onset alludes to the fact that there was no childhood confusion. There was no childhood distress with their gender, and typically our sense of self is pretty stabilized by puberty. We tend to know if we're male or female much younger than that, but this is something where there was no distress noticed, and so it can really blindside the person, it can blindside people, the people that knew them, the families, etc. And it's not, like I said, it's not a formal diagnosis, but it's a description that is helping us understand what gender-related distress is looking like currently. Okay, we'll go to the next slide. So prior to this, I've been talking about gender dysphoria, which is a medical condition, a mental health condition. Transgenderism, however, it's a different word, a different term. It's essentially gender identity, so it's an identification with an expression. And this identification is essentially an expression of self and identity and how one sees themselves that doesn't align with their natal sex. It does not always present with gender dysphoria. So I think that's a really important point. Someone can walk into a medical clinic, a mental health clinic, and say, I'm trans, and they are shockingly put on hormones, which is a medical treatment, when this is not a medical issue. And I find that to be worth talking about. So this is a coping mechanism. This idea of self as an opposite sex is a coping mechanism and a declaration of who I am. The individual is an identity that's been often self-selected. It often stems from, and I think it's really important to understand, it stems from some sort of disorientation, some sort of distress, some sort of suffering that is very real, and it really needs to be uncovered and dealt with. We'll go ahead and, I think that's that on that. Next slide. So again, I really want to focus on gender ideation. You can't have a coping mechanism without having the thought process behind it or an idea that this is a solution. So gender identity was only a theoretical construct that was introduced in the field of psychology in the 60s. And this is, again, a theory of why someone can have an internal sense of self, the soul, essentially, the gendered soul, which is an idea or a theory or a belief system, essentially, that suggests that someone's inner soul can be different than their physical body. And this was, again, really relatively recent in terms of history, 1960s. Ideation, I define that as the internal process of imagining oneself as the opposite sex or something outside of one's biological sex that sets the entire trajectory into motion. It's essentially a period of questioning. And I kind of chuckle because that's like the task of teenagers. That is their job, is to question their sense of self. It is a very known developmental process that we all go through. We didn't all go through it in a culture that affirmed the ability to opt into a different sex. So this period of questioning I look at it as a window of vulnerability, a period of vulnerability where their risk factor for developing gender dysphoria or transgender identity is exponentially, the risk just goes up when you're a teen because of this process and this need to differentiate yourself from your parents, to be different than your mom and dad, to be different than your siblings, different than your friends. And that is very healthy. Typically, we probably all have memories of that. I do. We typically try on different versions of ourselves. Those versions of ourselves could be just simply hair, fashion, music, friend groups. You know, typically it is an expression that is observable on the physical body, but it is also very normal and very fluid. It's not stable. It doesn't just usually stay for life. We saw the evidence of Gabe's photos. So, with gender identity, this period of questioning, the transgenderism essentially offers a young teen a name for the pain. It gives them a script to follow. And that is very comforting if you are growing up in if you're going through that stage of development and things are not so certain and things are very scary and overwhelming. So just a couple of open-ended questions to think about. Why does a child begin to identify as transgender in the first place? It's a very individual answer. Again, I think it's important to acknowledge the fact that with the different type of treatments, I'm going to get into that soon, the way that it's happening right now, currently in the mental health field in the United States, it's very much a one-size-fits-all approach. Everybody is put on the same trajectory. And I think that's never how we handle mental health. Mental health is individual, it's custom. We all have a myriad of factors that contribute to why we do what we do and why we think how we think. So I think it's very simplistic and overly, just very narrow. And then what motivates them to change their name, change their pronouns, their clothing, and even their bodies? The debate. This is obviously very hotly debated. We'll go to the next slide. So the debate is two perspectives, gender-affirming care and psychotherapeutic approach. So I'll break those down. So what is currently happening in the United States mental health field is gender-affirming care. This is, quote unquote, the standard of care, which is most of the medical clinics and agencies and most of the mental health training, education, all of this is following this gender-affirming care because it has been decided as the standard of care. It's interesting when you develop a curiosity about what's driving this. It's the association who decides the United States standards of care for transgender issues is WPATH. And that is an acronym for the World Professional Association of Transgender Health. So this is what the American Psychiatric Association follows, the American Psychological Association follows. But when you really peel back the curtain, what is WPATH? I got off my slide. WPATH is an international professional organization working to further the understanding and treatment of gender dysphoria. This is pretty hot topic because in 2024, I believe it was, there was a widespread scandal with leaked files, and those leaked files were very disturbing. I watched some of them. There was a widespread known medical malpractice happening in this organization where doctors were recorded and staff members were recorded laughing and demeaning patients and talking about how they know that their patients can't understand the irreversible lifelong effects of this treatment, and they were doing it anyways. So they were often prescribing cross-sex hormones and other surgical measures to vulnerable children, vulnerable adults who were not in a mental capacity to give proper informed consent. So that might mean someone with schizophrenia. There were cases in the leaked files of children with schizophrenia who are seeing things, hearing things, smelling things, tasting things that don't exist, and they're being affirmed in their decision to follow this medical pathway. Individuals with multiple personality disorder, it's now known as dissociative identity disorder, so someone who might have a female part of themselves and a male part of themselves in terms of just a lot of different personalities that are presenting, which is almost always trauma-induced. They were being put on medical cross-sex hormones. And the list goes on. Children with autism, other neurodevelopmental disorders. It's really, really upsetting and terrible. So it really pushes the issue of informed consent. So in these cases, I think there's a clear argument that no true informed consent was given. Because if you don't know what the complications could be, if you can't mentally understand and or grasp the possible side effects, then you're not able to truly consent to what is happening. So this idea of this organization setting the standard for all of our mental health care is, I think we're seeing a lot of this, arguably medical malpractice that has just been pushed down into a lot of clinics and organizations. Instead of, I think it is important, that last point there, the 8th standard of care is what we're in. They revise these every few years, and currently it's the 8th standard of care. And in this, and it really did incite a lot of advocacy groups to look a little bit deeper, because in the 8th edition of this, they actually took out age limits. So they were recommending medical surgery. There is no age limit currently, which is appalling. And the other thing they took out is this diagnosis of gender dysphoria is no longer needed. And again, I just posed the question, why would you prescribe a medical treatment for something that does not require a medical diagnosis? That's inconsistent. The other thing that's happening with gender-affirming care is that medical professionals often suggest suicidality, and that is the scare tactic that is used to convince parents, to instruct parents as to what is the right thing to do for their vulnerable child. They often are suggesting things as shocking, and I've heard this myself. First session, would you rather have a dead son or a live daughter? Would you want your child's blood on your hands? This is what parents are being told. And they're often suggesting that if you don't comply with this WPATH 8 standard of care, a gender-affirming care model, then you are risking suicide. And this suicidality, the way it's being talked about, which is, again, it just kind of like pricks my mental health mind, because that to me is a suggestion of an individual's inability to cope. And I think the whole point of therapy is to teach people how resilient we are, how capable we are of coping with all kinds of distressing feelings. And so families are often being heavily influenced to adopt this treatment for their children. I think next slide on this. So I went into that one already. The science is not settled in terms of this affirmation model. I would bring up, oftentimes in the field of mental health, there has been a law banning conversion therapy. And conversion therapy defined is causing harm to a person to attempt to change something they can't change. Nothing could more arguably fit the definition of conversion therapy than using hormones and surgeries to destroy someone's health in an attempt to change something they cannot change, which is their natal sex. Okay, next slide. What should happen? Psychological approach to care. This is psychotherapy. This is a psychotherapeutic approach to gender distress that has been, we have proponents of this model for treatment as well. The standard in all of mental health is therapy first. That is, for any mental health diagnosis, the standard. But this is not happening in our clinics. Once kids self-declare trans, they are put on hormones. Psychotherapy, however, is a very well-known, over a century-old practice of collaboration with a client. It is not prescriptive. It doesn't tell someone what they need to do with their life and how they go about it. It is a process of discovering with someone what is in their best interest, and it is a very collaborative process and not a cookie-cutter, one-size-fits-all process either. The other part of this that I think is important to note is the comorbidity. Oftentimes, once someone is ID'd as transgender, the other underlying mental health illnesses are not treated at all. So that might be autism, that might be ADHD, that could be obsessive compulsive disorder, body dysmorphia disorder, and there's so many, but these things are often neglected, which trauma histories aren't even being explored or asked. So, you know, in working with a lot of the prominent experts in this field, I can tell you from all conversations and all kinds of meetings, the therapists are not seeing this. In other words, children are not given an actual assessment. They're not giving a psychosocial assessment of their childhood history. They're not exploring, they're not asking questions, and that's it's really sad. So the other part with the parents, historically, when you are dealing with any mental health diagnosis, the parents and the family system are the support system. So they are a protective factor. Everybody does better with family support, no matter what you are struggling with or enduring. And so it is really shocking when you are working in the trenches of this particular battlefield that parents are not being included. And when we talk about, you know, schools changing kids' pronouns and that whole, there's a lot more just current debate that we could get into. There's a lot of things happening that are not including parents, and that's really upsetting because parents are, the statistics and science is settled on family and how family is important for our mental health. So it's important to talk about that. The next slide. So why does this matter? Because the effects of gender-affirming care are very, very serious. You can see the list there. Physical effects include things such as infertility. Once you have been on cross-sex hormones for 2 years is the estimate. Again, there's not a lot of longitudinal study because it's so recent. So what do we know? Not much, not enough. Enough to know it's experimental, and enough to know that approximately 2 years in, a person's infertility, their fertility likelihood is almost nil. The infertility risk is really high. Lifespan decrease. I read some research that suggests on average 20 years dropped from the lifespan because of medical harm, physical harm. Sexual dysfunction, pain, inability to orgasm. Nobody's talking about that. But your sex hormones drive your sexuality and your sexual functioning, and therefore when you, we don't know yet what happens when you flood a male body with estrogen at high doses for long periods of time. We just don't know. What does that do to the brain? What does that do to the developing brain? And vice versa. But we do know that there is a subset of population called detransitioners who have detransitioned, and they are talking And some of the things that they are very upset about is the medical harm that they endured, and the fact that many of them never were able to experience healthy sexual functioning because their puberty was stopped. That is not something that is irreversible. That is something that you never get a second run at puberty. And so it's a window of development that if you miss it, it causes lifelong implications. Pelvic floor dysfunction. What is that? Basically, your ability to empty your bladder and your bowels. With nearly 95% of girls on cross-sex hormones are reporting this complication. And we're talking about potentially 17-year-old. You want to talk about depression. If you're 17, 18, 20, and you can't urinate properly or incontinent, you are now dealing with things that we don't deal with till later age stage. So incontinence is a big one. Pelvic floor dysfunction is, like I said, 95%. And 52% of these females experience vaginal atrophy, which is a thinning of the vaginal walls. This is common in menopause. This shouldn't happen in our youth. Why does that matter? Vaginal atrophy leads to vaginal tearing. That means sexual pain for the rest of their life. Likely, possibly, inability to orgasm. Risk of heart attack increases 5-fold for girls, for females. Nearly a quarter of males develop osteoporosis and a high risk of pulmonary disorders. Pulmonary endometriosis, other endocrine disorders. So serious. Genital surgery complication rates for male to female is 70% complication. For female to male, it is 76%. And there is no other area of surgery in modern medicine that would tolerate or accept this degree of post-surgical complication. Surgical patients, just to give you an idea of some of those complications, they're at a high risk of fistulas, which is basically a tunnel developing between parts of their body. They're in their sexual organs. Urethral structures, which is a narrowing of those structures in body cavities. Tissue death. Infection, ingrown hairs where you shouldn't have ingrown hairs. Things that people are not being told about in their informed consent process. And psychological. This is, I'm clearly, biased, but impacted by mental health. I live in the world of mental health and I work in the world of mental health, and I just think it's really, despite all these physical complications, I think one of the saddest things you can do is deny yourself, to reject yourself, to discard yourself. And that is a psychological harm that these people are dealing with. How do you split yourself from, they refer to their previous pre-trans self as a dead name. That is a suicide. That is a rejection. That is a extreme body shaming and extreme bodily harm, mental health harm. Regression. So many times somebody who would have normally functioned with a high sense of ability is being looked at as disabled. They are not performing at the same level prior to their diagnosis of gender dysphoria or their identification as transgender. They are regressing into kind of more, they're not developing functional lives where they're going out and feeling good about themselves and working in the world and producing in the same way. Family parental alienation, this is a big one. It's splitting up a lot of families. I would imagine there's probably a lot of families in here affected. Most people I talk to, someone in their family is going through this. If it's not a child, it's a cousin or a nephew or somebody related to somebody that you know, and it's affecting a lot of family health. And then betrayal of trust by authority figures and medical professionals. When you trust, we're taught from a young age to trust the white coat, and we do. And these kids do, and they've been misled. And there's a lot of just hurt and betrayal and anger for those who went through unnecessary medical procedures. And then regret. Regret is not treatable. That one hurts. Once you have regret, you have regret. You can manage it, you can come to a place of acceptance and forgiveness, but you can't go backwards. And then I think it's really important to mention suicide, because obviously this is to be taken seriously. It is a concern whether you are transgender, pre-medicalization or post-medicalization. The suicide statistics are being promoted as up to 40%. A lot of these studies are questioned as well. But we do, contrary to the myth that transitioning will decrease suicide risk, we also have statistics showing that gender transitioned patients are 19 times more likely to commit suicide than those who don't medicalize. So clearly, it's not the solution. Gender dysphoria is not a solution to a problem. It's not a diagnosis. It is a symptom, I guess is a better way to put it. It's a symptom. Gender medicine under review is the next slide. How am I doing on time? I have no idea. Okay. So one of the authors that is pretty prominent in this field is Miriam Grossman. Miriam Grossman wrote this book. I have it here if you want to flip through it. But she's a child psychiatrist who was raising the alarm bells before the rest of the world was aware it was happening. And she talks openly about the need for more involved parents, more involved families, more developmental, more questions, more exploration, more actual biopsychosocial history taking, and more proper mental health care for this population. And again, she really focuses on the fact that a lot of this gender-affirming care is not addressing other comorbidities or other underlying issues that are being neglected and are continuing to harm. She also warns, as I just spoke of, the increasing risks or the very known risks to transition surgery. Okay, next slide. The CAS review, this came about because in the UK, this occurred in England. In the UK, there was enough complaints and whistleblower actions there that caused them to do what's called a systematic review of the literature. So they hired a professional researcher to study all the research out there and the clinics and how they were operating. And she did a very thorough, very professional, highly regarded report. And her report summary, she says, the evidence base for gender-affirming intervention in children and adolescents is remarkably weak. Most of the studies were low or very low quality, short-term, and lacked control groups. So her conclusion was very alarming, and it is being replicated and duplicated in a lot of European nations. And the United States and Canada were behind the curve on that one. So she also talks about social transition. I'm not going to spend a lot of time on that, but social transition is, accepting the pronouns, changing the names, having a social transition that is being affirmed versus a medical affirmation. And the research is quite clear now that this is not a neutral act. So it is an act. It is an act that, it's a hard one to make, and it's something that should require a lot of prayer and thoughtful conclusion, but it is not neutral. And what that means is we know now that it at least propels someone on a trajectory, and that trajectory is a different trajectory than they would have been on had they not had a social transition. Next slide. And I want to back up just a minute with the social transition piece, because oftentimes I think in our society, we do care about kindness, and we don't want to do, I hope, we all don't want to do harm to people. That's the intention, right? So when you hear about social transitioning, it's often discussed in a context of not wanting to offend, not wanting to harm, not wanting to cause mental distress or discomfort to somebody. And so it's often used in that context of helping and not harming people. And I think it's just worth acknowledging that if this is not a neutral act, if it does propel them onto a developmental trajectory that's different than they would have been on, is that help or is that harm? You better know the answer to that before you choose how you respond. We owe people that. Okay, so Jamie Reed is a United States whistleblower, and she came forward with alarming firsthand witness and exposure as a, I believe, social worker and one of our case manager, Washington University Transgender Center in St. Louis, that's right, St. Louis Children's Hospital. And she was wanting to help a very vulnerable population of kids and believed she was helping. And one of the things that stood out in her talk, she's done a lot of public dialogue about this. One of the things that really stood out to me is she made a point. She said, if 100% of kids that come into your clinic are diagnosed and treated with gender dysphoria, how is that possible? Any mental illness is going to have some that don't qualify. You are or you're not. You might, you don't. It's never 100%. And so that really alarmed her and really frightened her. And she came to the position that she was part of the problem. And so she spoke out, very brave. And this was her affidavit. She said children were prescribed puberty blockers or hormones after minimal evaluation, sometimes 2 visits. Parents were being pressured to consent, and concerns were minimized. She provided state investigators with documents and proof. And there's also some advocacy groups, and they are now, they have appealed to the FTC, the Federal Trade Commission, and this just happened in, I believe, just 2025. There's so much happening so fast, my brain's a bit flooded. But the FTC just had a hearing for 8 hours where they were interviewing and taking, they were taking a deep look into this, and they were gathering data and gathering information, and they are now actively ongoing looking into the possibility of medical fraud, lack of informed consent, and just basically, the Federal Trade Commission is also one of the organizations that monitors are being lied to by media, are being lied to by marketing. That's the word I was looking for, by marketing. So we've been marketed this stuff, and they are looking into that actively currently. So the call for this that Jamie has made is to increase regulatory attention, to have transparency, to have true consent, and to report data in this field of gender-affirming care. Next slide. Global ripple effects. Following the CAS review, Sweden, Finland, Norway tighten their regulations and no longer promote this gender-affirming care model. Similar debates are happening here currently, and NHS, which is the organization that runs this in England, announced puberty blockers were no longer prescribed outside of formal research trials. So there has been a global effect where they are, again, we're behind the curve. Europe figured this out years ago, that it wasn't effective and was causing more harm than good. I think it's really, I'm happy to report that in February of this year, so 2 months ago, there were 2 major United States surgical associations that changed their tune. They updated their formal position on transgender surgical care for minors, moving toward a more cautious approach and advising that most procedures be deferred until adulthood. So the American Society of Plastic Surgeons has taken a public position on this now, recommending that any sort of gender-related surgery is delayed till after 19. And they are basing it off the evidence that there is considerable uncertainty regarding long-term outcomes for these types of interventions. The other association is the American Medical Association, so another big one. They just announced in February that they are deferring surgical interventions in minors, citing a lack of strong evidence. They also state it is not reversible, and it continues to support access for other types of treatment for adolescents. Okay, next slide. These are two of the faces behind the names. Dr. Miriam Grossman. She says, we've allowed a generation of children to undergo medical interventions with weak evidence and uncertain outcomes. And this is who authored this book. There's lots of really good resources. That's just one. Dr. Hilary Cass was the New England systematic evidence-based reviewer who came to the conclusion that there was little scientific evidence for these interventions, and she says our children deserve truth, not ideology. They need time, therapy, and love, not hormones. Okay, and then, next slide. GenSpect. GenSpect is an organization that is an evidence-based alternative to WPATH. So they came about in opposition to this gender affirmation model, saying, wait a minute, what about therapy? What about therapy first? So they're an organization that's founded really recently, 2021, by an Irish psychotherapist and those on her team. It's now a very powerful international network of therapists and professionals, doctors, researchers, parents, people who are speaking out and wanting better care for this population. Their mission is to promote evidence-based, ethical, holistic approaches in gender-related distress. They advocate for what's called exploratory therapy or developmental therapy, which means look at the whole developmental process before coming to any conclusion. And their public statement, our aim is not to deny care, but to ensure young people receive thoughtful, well-informed treatment. Okay, next slide. So there's a bit of an overlap. There's some shared themes here, they're all emphasizing we need more safeguarding, informed consent for minors, weak evidence. We need stronger evidence before we make these types of interventions. Their advocacy for multidisciplinary psychotherapeutic first care. So the push is not for no care, it's for better care and system reform. Okay, next slide. Christian lens on this topic of suffering and identity. There is a biological and spiritual reality. There are the biblical truth, humans are embodied souls created male and female. All people bear God's image and deserve dignity and compassion. Within the biological reality, I think it's important to go back to the basics. There are two gametes. Gametes are mature reproductive cells. There are only two. There are only two that have ever been discovered. Men, produced by men, sperm, produced by women, eggs. So sperm and eggs are the only two reproductive gametes that have been discovered that exist. And a person's biological sex is nearly always discernible by the gamete that their body does produce or could produce if there wasn't a medical injury. A person's biological sex does not change if their reproductive organs don't function, or if they are removed, or if they choose not to procreate or cannot procreate. So biological sex is determined by gametes in binary. There are only two. There is not an in-between of sperm and egg. In terms of clinical integration, how to help this population, how to help these cases, it really is important to address the emotional pain and the spiritual longing that is underlying that distress. Encourage identity coherence and bodily stewardship in light of faith communities and faith commitments. Encourage a positive sense of belonging, connection, and purpose. That is a big part of this. Offer space for hope and lament and healing and growth and overcomingness. So affirm the pain, affirm the feeling, affirm the suffering, but do not affirm the identity. That is the takeaway. Okay, next slide. Speak the truth in love. This is the most important slide, for sure. We need to always operate from that model and operate from a place of kindness. And if I have a couple more minutes, I wanted to read a poem that was written by a parent There are a lot of parent support groups that are active. This particular, it's called PITT, P-I-T-T, which is Parents with Inconvenient Truths About Trans, and they often are, it's an online community where people, professionals, parents, anyone really can kind of write about this, blog about this, share their thoughts and experiences. And so this was one that really is quite emotional to hear, but I think it's important to hear it. This is written by a parent of a trans-affirming son. It is called, "If You Only Knew, a Letter to Others Who Affirm My Son." If you only knew what it is like being told by your adult child that he believes the horrible is possible, that he was born in the wrong body and is going through treatments and procedures to right what he sees as wrong and fixable. If you only knew how it feels to listen to your child read a prepared script outlining the new rules for being his mother, telling you not to use the name you so lovingly picked out for him, to honor loved ones who died and are now established guardians over their namesakes, telling you that this name, which rolled off your tongue like a song, is now a dead name, and you must use another one, which sticks in your throat and cuts like barbed wire. If you only knew how it feels to watch your son take drugs that are harming him in the long term, even as they falsely uplift him in the short term, how he has already altered his body and mind in a charade of repairing what is not broken, how it feels to know each poison pill he dissolves under his tongue could be rewriting his destiny and shortening his lifespan. And you know it because there is scientific evidence, the same science that determines him as male, but that he shuns as similarly as he rejects his biology. If you only knew how to learn to hide the daily silent tears with a forced smile, to silence the growing screams, to pray that your broken heart will not someday just explode from anguish, to watch your child self-destruct into a delusion that society has shaped him to believe. And how society has embraced him, even as I, his mother, and thrust into void, a version of the emperor's new clothes, while friends, families, and casual acquaintances celebrate and glorify this new twisted iteration of the miracle that was my son. If you only knew how it feels to dread weddings and family celebrations and events and even funerals because you have somehow developed a sense of shame. You feel the judgment of those who will whisper and gossip and pity and blame you for the unwitting indoctrination of your son. The left field new reality that has been foisted on you, and though you pray every day that it will change, you still feel that this is somehow your fault, and you are found lacking in the eyes of those who are looking in. If you only knew that my son has become a completely different person, with glimpses of his former carefree self, but with the facade of a badly drawn caricature now permeating his every word, step, mannerism. And that he has changed so drastically, you no longer see the boy who is growing into a man. If you only knew how it feels when people like you say, if you loved your child, you would accept this into your heart, do what is asked of you, and you will embrace the new daughter you have now, because, oh, by the way, that's still your child. But you don't know. You don't understand, and you never will. You can watch from afar and approve and affirm and agree and enable, because anguish is not a part of the role that you have taken on. All you've had to do is learn a new name and use the pronouns that naturally and objectively go with that name, even as they don't go with the person assuming them. And to you, it's as easy as changing your socks. If you only knew that you know nothing at all. And that was a very heartbroken parent that wrote that poem, and I wanted to share the impact on families that this is having. That's it. I did author a book on eating disorders. That's not the topic of today's talk, but it's another thing that I am very passionate about. And if that is affecting anyone in your family, I did bring a few copies, and I'm happy to share them. It's a guide to help parents through that nightmare, and nightmares come in many shapes and forms. Thank you. Thank you.